introduce Dr. Jenkins.
Thank you. Thanks, man. It's an honor to be here. This is my first time at the meeting, and hopefully it won't be my last, assuming you guys have me back. I will say I have a lot to go through here, so I'm going to try to move along quickly. If I'm moving too fast, raise your hand. Let me know. I'll try to slow down. Also, I tend to be more physically interactive than digitally interactive, so I poll the audience. I would like you guys to actually raise your hands, okay, just to get a sense of where we're at. The Bertolotti syndrome, and I say Bertolotti because it sounds like Mario Bertolotti, but there's no right or wrong way to pronounce it that I know of. We call it B-Sci rather than BS. Patients are really tired of being told their symptoms are BS. Even if you mean well, it still sounds very bad, so we call it B-Sci. And that's a nod to Mike Steinmetz, who's one of my co-collaborators on this subject. I know he's given a talk here in the past. So I am a neurosurgeon, full-time faculty at Mount Sinai, 17 years. After that, decided to go into private practice 7 years ago, but continue to do research on a number of subjects because it's fun, because I like to learn new stuff, and I like to raise the bar. And this is an opportunity for me to share some of what I've learned over the last 15 years of studying this condition that wasn't on the boards. Nobody ever taught me this during residency. I first heard about it from a patient who said he had Bertolotti syndrome, and it turns out he actually didn't. He had a adjacent segment problem. But it got me thinking about a condition that I had no knowledge of, and there's a reason for that. We're going to get into that. So first of all, I have a few disclosures to make. I have nothing of conflict with regards to the talk I'm giving. I am a minority investor in 2 companies, which have not made any money yet. I'm sole owner of a different technology company that has 7 patents but no revenue yet. So I'm open to more conflicts of interest. What I'm going to tell you, I'm going to tell you what I'm going to tell you, I'm going to tell you, and then I'm going to tell you what I told you. Congenital anomalies can cause pain. You've heard it, it's published in the literature. You can't have pain from a congenital anomaly, or you have had pain your whole life from birth, and that's actually not true. Throw that, wash that out of your brain. Bertolotti syndrome is a real phenomenon, and it's almost embarrassing to stand up here and tell you this, but so many people, and it's published in so many places, that gets it wrong. I am not going to attack Antonio Castaldi. He was a lion. He did a lot of great things. But his classification system needs to go. It's just completely has nothing to do with modern medicine. You, in the audience, can help these patients. These patients actually can do very well, even if they come in and they feel like they've been treated poorly for years. You can actually make a difference in their life. And that the treatment, when tailored to their specific anatomy, can be very effective. So lumbosacral transitional anatomy, we've seen this, we've all seen it in our patients' films, not knowing what it was. You were told at one point during your training, these aren't important, these don't cause pain, ignore them. It's not actually true. These are one spectrum of transitional anatomy. There's lumbosacral transitional anatomy. There's also craniocervical, cervical-thoracic, and thoracolumbar transitional anatomy. And each of these is often can run with others. So if you see one, it might behoove you to look for others, especially if they're complaining of pain in another part of their body. So just a little quick, we all know this because we have to study this for our maintenance certification if you're not grandfathered in. It starts out with scleroderms, notochord, turns into ribs, transverse processes, or an aorta. And sometimes it gets a little bit hybridized. The transitional vertebra can be unilateral, bilateral, and asymmetric between the 2 sides, where you can have sometimes multi-level disease, and you can have, one of the biggest problems is that the classification that we're going about to explain why we don't use it anymore, doesn't take into account the fact that in many of these patients, the anatomic variations come from both ends, lumbar and sacrum, and it's not just a lumbar tumor. But it also causes hypoplastic discs as part of the hybridization. After all, you have your synchondrosis of your S1-2, and this is kind of halfway in between. We call this for now L5S1. You can see this is smaller and not degenerative. Not to say some of these patients don't get degeneration, they can, but there is nothing inherent about this that not every small disc is a degenerative disc. In addition to that, the facet joints can be hypoplastic at the transitional level. My apologies, this was supposed to show a much bigger lumbar L4-5 joint and a much smaller L5-S1 joint. I'll show you that again later. In addition, the muscles that span this area are hypoplastic. Okay, they are a hybrid between being a partially sacralized body and a partial normal lumbar. You can see here the thickness of the muscle attaching to the L4 transverse process and the paucity or extremely underdeveloped, mostly fat replaced muscle that's attaching to. So it's a multifactorial transitional anatomy. It's not just a transverse process problem. Now, as we said, that these can be classified in multiple different ways, looking at type 1s, type 2s, type 3s, type 4s, and it's important to understand that each of these subclassifications that I have developed to try to understand these better are specific to a type of patient population, a type of presentation, and a type of treatment. Each one of these rows gets a different treatment, and this is important to understand that this can affect somewhere around 5 to 6% of the U.S. population. That's that many people could be having this type of problem. That's a hugely underappreciated patient population. These present as one or more of the following: back pain, leg pain. In fact, it's typically an L5 radiculopathy, and there's a reason for that. Groin pain. This is also because part of L5 can go to the genitofemoral nerve. Sacro-Iliac region pain, well, it's right next to the sacro-iliac region. And hip pain, because sometimes these transverse processes rub against the iliac bone and can have actual hip pain. And I've seen patients get hip replacements and get no better, get this treated, their pain goes away. It's one of the few conditions where not every patient, but maybe 60% of patients will tell you they get pain lying in bed, they get pain turning over in bed, or they get pain they wake up with pain in the morning. There aren't many. Discogenic pain usually feels better when you lie down. This is different. So why don't we know about this? Well, in life, it's not what you don't know, but what you know that ain't so that gets you in trouble. It's when you confidently go in the wrong direction. How many of you in the audience know that congenital anomalies can't cause back pain? Anybody? I was taught this, okay? This is what I was told. So if dogma is a commonly held belief, not evidence, belief, then rogma should be a commonly held false belief. And this is one of those. Historical background: many authors since Bertolotti described LSTBs and Bertolotti syndrome. Going back from the 1930s, he published in 1917, right up until 1980, this was a hot topic of discussion. Castaldi published his classification system in 1984 based on pre-MRI data. This was intended to find disc herniations in the pre-MRI era to avoid, to try to screen out which patients with back pain and leg pain had disc herniations. It had nothing to do with back pain. In fact, his whole classification article never describes a single symptom. And so obviously the idea was to try to avoid myelographic, violation of the dura if you didn't have to. So what's wrong with this classification? He had 200 patients. They did myelographic evidence of a disc herniation. However, he didn't describe who was included, who was excluded. His classification had 199 patients that didn't have a spondylolisthesis. Only one patient in the series. We know that the incidence of that is much higher. In addition, he described that disc herniations in 3-4, 4-5, and 5-1, which isn't terribly useful as a screening tool. And he also uses the 19-millimeter transverse process as one of his criteria. Well, we all know that transverse processes aren't tumors, so their physical size is less important than the proximity between them. So in general, the point of the classification system is for you to draw some conclusions, for you to stratify patients. He doesn't do that. There's no evidence, he gives no recommendations based on his classification system. It's a classification system without purpose. And nowadays you just get an MRI. There's no reason reason to use this classification system. However, and then of course also the classification system misses 75% of the type 1s that are symptomatic, proven with injections, proven with surgery to be responsive. They'd be missed by the histology classification system. Why do we still use it? Because he's famous, so he must be right. He's dead, so we can't ask him. No disrespect, but this has been around for a long time, primarily because of inertia and because of people's misinterpretation, misquoting. Here's an example from the American Journal of Neuroradiology. Therefore, these have no relation to what was initially described as Bertolotti syndrome. They're calling into question the whole diagnosis. It's not even what he said in his article. But people have been misquoting him for the last 40 years. And it's dogma or wrong. So let's get back to what we do know. So Bertolotti syndrome is having an LSTB that causes the pain. Not just having an LSTB. It's not a radiologic diagnosis. 40% of people with no symptoms have some type of radiologic finding. You know that in disc herniations, you know that in spondyes. Many people walking around asymptomatic. So what are we looking for? We're looking for, as I said before, back pain, leg pain, groin pain, SI region pain, or hip pain. I know this makes your life a little bit more complicated. It's easy when you see a spondy at 4-5 to just say automatically, that's the pain problem. You see a disc bulge at 3-4 or 4-5 and say, that's the pain problem. You actually do need to consider this diagnosis in your workup of these patients if they have the anatomy. If they don't, move on, it's easy. But you do have to make sure they don't have the anatomy. And as I said, this is one of the few conditions that causes pain not in a typical discogenic pattern. So these patients can present 8 to 80. 100% of these patients had no pain until something happened and they developed pain. Sometimes it's a gradual onset, sometimes it's an accident, sometimes it's a fall. 95% of my patients at one point or another were told there was nothing wrong with them. And many of these suffered for years or decades because they were essentially gaslit by their doctors who knew something that wasn't actually true. They do turn to social media, and they turn there in droves, and there are places that I won't even go to chase after some of the Bertolotti's support groups. So x-rays, often patients will come in from an ER with back pain and they'll say, oh, there's nothing wrong with these x-rays. You gotta get a Ferguson view, because a Ferguson view looks straight up the disc space and allows you to see without overlap what the transverse ala interface actually looks like. CAT scans, really it's the workhorse for your Bertolotti's workup. First of all, you do need to count whether they have transitional ribs, how many actual vertebral bodies they have. Does it matter for their outcome? No, but you want to be able to tell the radiologist or the surgeon or whatever else, you want to know how many lumbar vertebrae they have, so when you say L5 or L45 or L5S1 or L5L6, that you're speaking the same language. Here is one example of a facet joint that's larger, and here's one that's smaller. I did say I'd give you a better review. MRI is actually a little harder to interpret. Everybody gets them, but if they don't give you a T2 coronal with very narrow cuts, you get a lot of volume averaging and it may be less useful. In addition, if they don't do the sagittal slices far enough laterally, you're going to miss these cuts where the transverse processes are close to the ala. But you can see here, in this case, the transverse process is large, coming down to the ala. Here, there's a small gap in between them. These are things you can see. You're not looking at a midline cut. You've got to train your brain to look at all of the cuts. This one, actually up here, this is from the scalp. You know when you get you get a few cuts from each of the 3 different orientations? Look at the scalps. What isn't helpful? SPECT. And it seems like it'd be a good idea. If it's causing pain, it should show up in SPECT. It doesn't. 95% of my patients who've had SPECT scans are negative. I mean, here you can see here, well, it lights up where the marrow is in the middle of the vertebral body, but no lighting up whatsoever where any of the interfaces are. So, how many lumbar? The way I look at this is, if you have a well-formed floating rib, that's going to have a different impact on your mobility transverse. So you can have sometimes a fully formed rib on one side and a transverse process on the other. I would still call this T12. But sometimes you have these tiny little riblets that look like they're just an afterthought, they're just glued on. I would consider this a lumbar vertebra. Here it's got a transverse process and this tiny little riblet. And I use 4 centimeters as the frame of reference because that's longer than most transverse processes ever are. But it's important to speak the same language. So if you can have multiple transverse, so here's an example of a patient with a type 2 anomaly, and then at the level above, they have a type 1. Here's another example of the same type of anomaly. And I've even seen ones where there was 2 transverse processes, L4, 5, touching each other, and then a gap, but very close together. So you can get this hybridization at multiple levels. What else happens? They can have cervical myelopathy from congenital cervical stenosis. Hypermobility syndromes are very frequent. You want to look for multiple other syndromes associated with it. Ehlers-Danlos syndrome and its forms of hypermobility, craniocervical instability, thoracic outlet syndrome, all of these things run in this family. And while they may be challenging patients to take care of, they're often very gratifying when you fix sometimes there are multiple problems one at a time. They can have metal allergies, they can have vascular syndromes. So, what is it not? It doesn't cause weakness. I've never seen a patient with Bertolotti's have a foot drop. They have something else. No bowel bladder, unless it's from one of the other. They could have cervical myelopathy. You want to look for that. But if you see somebody with a foot drop, you're looking outside. You may be doing Bertolotti's plus something else. And in many of my patients, at one point about 50% of my patients were what I call Bertolotti's plus, were wound up operating on more than one problem at the same time. Diagnostic injections, they respond brilliantly if it's done properly. And I create these little diagrams off of the CT to help the pain management doctors. And 70% of my pain management doctors that have done the injections, they're not my doctors. They're doctors from around the country, around the world. And if you give them this type of a diagram, most of them can get it done. It confirms the cause and effect. You're connecting the LSD, the anatomy, with their pain by taking away their pain with this injection. Sometimes we have what we call positive negative, where it really ramps up their pain just by once the needle hits that area. They're like, that's my pain, and may not take away the pain. Those people tend to do pretty well too. But it has to be the same pain, and you have to make sure, oh, does it hurt? No, that's not the question. Is it your typical pain? But other than that, it's extremely sensitive and specific. And actually, one of my research minions, who's now a medical student at UVA, just presented at the Other Spine Summit, and his talk on the Bertolotti's injections just won the best talk in the MIS category. So they respond very briefly. So just because they only get 5 minutes worth of relief doesn't mean it didn't identify the problem. And there are many patients who get only about 5 minutes worth of relief. So if they do something that causes their pain, have them do it right again after they get the injection. Up to 2 weeks, this is not like a 3-month injection like an epidural. These things wear off very quickly, so just manage the expectations. So I do all of these injection diagrams to show where you want to put and at what angle, because many times the pain doctor will just want to come straight in, and because of the oblique angle the LSTV makes, you need to actually get in there to have the medicine get to the target area. So you can see here that there's this very oblique orientation. And this is what your screenshot looks like. Make sure they give you the screenshot to make sure they did it right, because if you have a patient who didn't get well from an injection, make sure it was done properly. What doesn't work? For this condition, physiotherapy just doesn't help. Most of my patients tell me, PT just makes me work, doctor. I have to do it again. Ablations rarely work. Maybe 40% work at all, and they're usually done in 2 weeks if they gave any benefit. Stem cells, PRP. There's a lot of people selling a lot of stuff that's not covered by insurance. It's a cash and carry business. It doesn't work. And doing the wrong surgery doesn't help. Interestingly enough, you think that fusing this level, if we're going to get to that, is the goal, why wouldn't an ALIF be a great operation for it? It just doesn't seem to be. And I've had to revise patients with solid ALIF fusions, but the transverse ALIF didn't fuse and they still have pain. We inject there, pain goes away. ALIF's just not the best choice. There are other reasons why. For example, we talked about the hypoplastic discs. Do you really want to shove an ALIF into a hypoplastic disc? The only way you're going to get the cage in there, any cage, is to jam it open, tear the PLL, and you risk actually stretching your S1 nerve roots. So I don't even do T-lifts for this type of condition. Same problem. Getting a cage into a tiny, tiny disc, it's just not a good idea and not necessary. So type 1s, transverse process, close to but not touching the ala, whether it's TP coming down or ala coming up, resection. And if they have unilateral symptoms, I tell them, you know, you could, if you've got bilateral anatomy and unilateral symptoms, pain might come back, but we're only going to do the symptomatic side, and if your pain comes back, we'll deal with it then. And what you want to do is you want to make sure that you, whether it's the transverse process coming down or the ala coming up, you level it off. You want at least a centimeter in between. Type 2s, if they have any type of not contact or not fused on both sides, whether it's proximity, full contact, but a pseudo-articulation, bilateral pseudo-articulations, they get a bilateral fusion. And the way I do this is through a 1-inch Woodsy approach. It's great. It's 2 hours or less in the surgery center or in an outpatient. 90% of my patients go home same day. So it's a great little operation. I actually have one patient who really ruined it for me. He posted on one of the Facebook groups that he walked home 2.5 miles from the surgery center. I'm like, dude, don't tell everybody that. You're gonna make it really hard for me. Type 3s are something that you think, well, if this is fused, and this looks pretty fused, why do they still have pain? And some of them do. When we do the injections there, it takes away their pain. And so what I wind up doing is just digging it out and refusing it. I think it's more like a surgical ablation. This is a very, very small percentage of the population, and it's one that I think this is a moving target still. Type 4s. Hey, how many times have we heard, if it's fused on one side, it's fused? Well, these patients are fused on one side and have pain on either side. You can have leg pain on one side and back pain on the other, and they do well just by fusing the one open side. Because the bone is a biological substance, it can flex. I have seen a couple of patients that have actually started to fracture through their fused side because they still have a disc, they still have facets. Why don't we do resections for type 2s? Everybody wants to do that the first time they see it. It looks big, it looks fun, it looks like it'd be an easy case. Well, to quote somebody else I know with a little bit, well, he doesn't have any gray hair because he's forever young, but as Dr. Anand said, it's freaking hard to actually get all the way down. You have to get into the pelvis, you have to get into the retroperitoneum from the back. And there's a lot of structures in there that don't take too kindly to carousels and other sharp objects. These are hypoplastic discs. Do you really want to try to give them motion at a level? You're going to rest all 24 vertebral bodies, or in some cases 25. You want to rest the entire spine on a hypoplastic disc? Oh wait, hypoplastic disc with hypoplastic muscles. They've never developed the muscles or even the brain pathways to control these non-existent muscles. So do we really think that that's a good idea? We tried. First of all, these also never move, so you're not losing any range of motion. You have 1 degree range of motion or less with a type 2 anatomy. You're not losing anything by fusing them. All you're doing is you're losing their pain. And we did try, and we saw a 60+% failure rate. I don't recommend procedures that have a 60% failure rate unless they are so sick or there's a really good reason why they can't tolerate the recovery at that moment for very, very good reasons. Because it's much better to be one and done than it is to come back and do this in a staged way. So here's one example. This actually is one of the cases we published. And so this QR code here goes to the article, which we released for public. We paid for it to be publicly available. 19-year-old, back pain, hip pain, body pain for 2 years, previously active, now disabled, out of college. Positive injection response bilaterally to the transverse process area. Now notice, this is not a 19 millimeter transverse process, so this would fail the Castaldi classification. But the ALA comes up. That's all it takes to be symptomatic. We did a resection, they did well, 0 out of 10 pain, back with their life. Here's another example. This also comes from one of our, actually that was the post-resection x-rays. Case 2, 35-year-old with back pain, worse on the left, failed to improve with an L4-5 TFESI, even though this L4-5 disc looks nasty. A lot of people would say that's the pain generator. But they didn't get better with an epidural at that level. But they did get better with Bertolotti's injections. So they went and underwent a bilateral MIS fusion. These are actually the screenshots from the surgery center. And 80% improvement in her pain, which has been maintained at 2 years, grateful, on with her life. Case 3, patient with hypermobility, back and buttock pain, underwent successful Bertolotti's injections, underwent a left fusion and a right decompression. This person actually had an LSTV, this was a type 4 on this side, so it's open on this side, fused on this side, but transverse in contact at the level above. So we resected at the level above on the opposite side and fused this side. And they did great. They had 90% reduction in their pain. Wasn't the only problem they had. She still has hip problems, so you just got to manage their expectations. This is not a hip surgery, but it does cause cure. It does treat some hip pain. Here's another one. She was a young person, was involved in a motor vehicle accident, had no pain before her accident, until she did. She got 60 to 70% improvement with her Bertolotti's injection. But then we did flex X films, and we saw that, yeah, she's got a little motion at the level above. She then got 40% improvement with her TFESI at the unstable level, and she's done great with just this operation. Now, one of the things that we love to talk about is that you need interbody to get a good fusion. First of all, in these patients, their bones are already so close together. They're trying to fuse. You don't need to do an interbody to get this to fuse. But this was a case where we got a good fusion without doing an interbody at the level above, and she's done great. There's a little shout out, just the type of things you see on social media. This is one patient who was really, truly marginalized. She came up from South Carolina to get her treatment, and she's done remarkably well. These are very grateful patients. So in summary, LSTVs can cause pain. Bertolotti syndrome, it's real, and you should be looking for it when you see a combination of back pain, leg pain, groin pain, any of these things. Just check. Do they have an LSTV or don't? If they don't, move on. If they do, you might want to make sure that's the problem. The Castaldi classification system was never intended to identify Bertolotti syndrome. It was never meant to treat it, but it's been so widely misquoted and misapplied that it's actually set back the practice of medicine by 40 years. I'm not attacking him, just but this classification system has no reason to exist in the MRI era. You can help these patients. You really can. Listen to them, query the pain generators, make sure that you're treating the right pain generator. And treat them according to their anatomy. Type 1s, resections. Type 2s, bilateral fusions. Type 3s, if they really are, an onlay fusion in that area where the cleft is. And 4s, unilateral fusion. I want to give thanks, of course, to the Mayfield Clinic and its support of this meeting, and to the program committee for allowing me to take up your valuable time. I want to thank my research team who have helped me to extensively put this out. I want to thank my patients for teaching me and helping me to gain the empathy to listen to them. And I want to thank all of you for taking the time to listen to me today. Thank you. I'm going to leave these up here for now. Just the classification, that's the first one, is the link to the article for my classification system, should you want to get it. The outcomes, that justifies why each of those different treatment strategies works. More information about Bertolotti's, and if you want to email me, I will send you the Castaldi, PDF of the Castaldi article for you to read it for yourself and see it just has nothing to do with this condition. And it shouldn't be applied because there's no purpose in an MRI area. Thank you. Any questions?
Thank you very much. Questions? Neil?
Actually, I think one of the best talks I've ever heard of this topic is so rare, you know, like we exist, it's there, it's real. But I really can't play it, right? If you look at it, these are means for that. It's following the path of peripheral syndrome, the SI joints, and you know, all these things that come up that are these absolutely pain syndrome generators supposedly, because we can find out what the pain is. And the worry is that if I go down that path, so let's take an example of that case you did. I'm sure your patient did quick. With an annular tear at 5-1, you injected the Bertolotti area at a single level 5-1. Had an annular tear, injected it. And you know the L5 nerve goes right there. You can just mask the pain with the L5 nerve. So if she had L5 nerve pain, your whatever you leak out is going to mask that pain. Then you go to a medical school, off knows the distance. She feels great. Yeah, you still don't know what causes the pain, but she feels great, right? So my point is, you know, once you do something, it's hard. I mean, I don't even carry it properly on 4 or 5. It's so rare, but I have a hard time believing that that is the only cause of pain. It's just hard. And then a spec scan comes negative. So things don't fall in place. Now, spec was positive. Are we more inclined? Maybe, okay, that maybe it is, right? But it's a hard diagnosis. I don't think it's easy. I don't think you should fall down the path of the peripheral syndrome. And putting SI joint, they put it out there. The 2 SI joints being done. And they probably better get something to me. That's not fun.
Well, I think you raise a great point, which is a point that I have always used in my practice. I don't operate, I mean, there are a lot of people out there, and if you look at this way, we're going to agree to disagree. They offer an operation like a fusion if they didn't get any better with an injection. I'm just the opposite. I will not offer an operation to a person who got an epidural at a particular level and they didn't get better from that injection. If it were off, that's different, right? But I do believe, and I found in most of my cases, that when somebody gets an epidural at a level and they get better, something to be done at that level will make them better, regardless of what the diagnosis is. So SI joint injections, they have to, many of these patients have negative SI joint injections, negative epidural injections. And it's funny, the Bertolotti injection is so specific to the Bertolottis, and for a while there, it was so common, I would require a negative L5 epidural and a positive Bertolotti injection. At this point, if they get the positive Bertolotti, it isn't coming from the disc. It's coming from the transverse aortic interface.
I will say clinically you hit on the nail. They hurt at night. It's one of the few things that do hurt at night. And especially the line of your back, it doesn't get better by flexing your knees or rolling on your side. Discogenic pain or even posterior facet pain, if you roll up on your side and flex your knees, you'll get that. I trained in Europe, and this was quite common. We actually spent this a lot. I never heard this conversation ever come up after I came to the US. But in Europe, it's not uncommon to talk about. And it was clinically, they did different. Like a discogenic pain, flex your knees, lie on the side, facet pain goes away. Not this one. This stays the same. But I want a spec scan to be harmful. That's the case.
I would like that too. I would love that. It just doesn't. 95% of the spec scans are negative, even though they've got injection positive. Any other I know I want to get on to the next talk. So.
Okay, no, I have a couple questions. First of all, I'd like a show of hands of all surgeons in the room who've done surgery for this syndrome. And how many have not? Yeah, I think education is really needed. It's really needed in this syndrome. One of the problems that I noticed, and I've operated on about a half a dozen of these patients, is that sometimes I've seen patients come to me, they've had pain for decades, they've only had an MRI. So you can't see it, and really, quite frankly, I've gone back and looked at MRIs where it is there, and radiologists did not put that in the interpretation. So just there's a lack of understanding and thorough, correct diagnostic testing. From a surgical point of view, I found that 3D image guided surgery is phenomenal for this. It makes it very easy. If you're just doing it with fluoroscopic and anatomic knowledge, then it gets a little scary because you're getting deep bridging, and I've done all of them with the imaging. The other question I had, I know we're belaboring this, but you said, I'm still a little confused about who should be fused. You said, I think you did some surgical decompressions without fusion.
We tried, and they didn't do well. Most,
How
not
many
all.
patients was that?
My first 20.
Okay.
So my first 20 type 2s I did as resections. And we had, in fact, actually, the number originally was 60%. We had 12 failures out of 20. Actually, more of them have now come back with failures and have needed to be fused. So it's not zero, and there are some people who do well with
Did
it.
they come back with spondies?
There are some people who come back with spondies, but interestingly enough, and this is what my group is working on right now, is the next publication on the subject, is that we've seen, if you think about this, 40% of patients with LSTVs have some kind of problem radiographically at their L4-5 level. This has been proved in 3,000 patient studies twice in Europe. It's documented that there's a 40% chance of having a problem at the adjacent level just by walking in the door. We talk about, if you do an L5-S1 fusion for normal anatomy, they have a 20% incidence of developing adjacent segment degeneration, right? That's the number we bandy about. I've only seen about 5% of my patients, and I've done close to 200 patients with Bertolotti's, over 150 fusions. I've seen maybe 5% come back with an L4-5 slip. It's not zero, but you treat the 5% differently than you treat the other 100, and you don't not treat them because this could happen down the road. So it's a great subject.
Well, I want to thank you for coming to Snowmass for the first time and giving an excellent presentation.